Thank you very much, Rick, for that extremely nice introduction. And thank you all for coming on this gloomy night. The brain is basically who we are. We all know that. And cognitive loss in the brain is a devastating thing for people, for their friends and families. So tonight I want to talk about some new work we've been doing, alluded to by Rick, about how the blood vessel system and the vasculature might interact with the Alzheimer's system to provide some of the pathology that's going on and also provide some therapeutic possibilities. So a little bit about Alzheimer's to start. Rick mentioned some of this. It's a neurodegenerative disorder. I'll come back to that in a minute. Millions of people worldwide are affected, and there are currently no effective treatments for this disease affecting these millions of people. Rick talked about this as well, and I'll just reiterate that if you look at the changes in causes of death from 2000 to 2010, we've been successful in a number of diseases. HIV is spectacularly good, but as he mentioned, in conjunction with this good news, there's the bad news. The deaths from Alzheimer's have gone way up. And this is, as he said, in large part because people are living longer. And the biggest risk factor for getting Alzheimer's in the general population is age. So we have an expanding population that's getting this disease for which we have absolutely no therapy. And that's, of course, a recipe for disaster. So the lecture tonight, I'm going to talk about three things, basically. A little bit about the characteristics of Alzheimer's. What is it and what goes wrong and what do we know about it? Its relationship to the vascular system. By vascular system, those who don't know the word, it's just related to the blood vessels and blood flow. And then stemming from these, some possible new strategies for treatment. So the story goes back to 1901, which incidentally was the year that Rockefeller Institute was founded on this site. And in 1901, this patient, August Dieter, was brought by her husband to see a Frankfurt physician named Alois Alzheimer. He was a neuropathologist. And Dieter had been exhibiting some, some very strange characteristics, including dragging sheets all around her house and what her husband described as frenzied jealousy. She was convinced he was having an affair, even though he was with her 24 hours a day, 7 days a week. So Alzheimer's conducted a series of interviews with August Dieter to try to get at what was happening in her brain. And in one particularly poignant exchange, I thought, he asked her what her name was, and she said she didn't know. And he asked her a second time. He pressed her. What is your name? You do know it. And she got frustrated finally, and she said in German, Ich habe mich verloren, which means in English, I have lost myself. And I've always thought this is very poignant because she didn't say, I am lost. She said, I've lost myself, which is what happens in cases where people have Alzheimer's and lose their cognitive ability. Now, this losing oneself has been beautifully and heart-rendingly exhibited by an American painter called William Utermohlen. William Utermohlen was an artist, and he specialized in self-portraits. Here's a self-portrait he drew of himself in 1967. In 1995, he was diagnosed with Alzheimer's at the age of 61, and he decided to do a series of self-portraits as his disease progressed to give some visual representation of what he was going through. So 2 years after his diagnosis, this is a self-portrait he drew. You can see that it's obviously recognizable as a person, but quite distorted. And just 3 years later, in 2000, this was the self-portrait. So you can just see the devastating effects in this series of self-portraits. So that's what we have to address and what we need to be able to stop, obviously. So what is happening in the brain of an Alzheimer's patient? Well, one thing that's happening is that cells are dying. If you look, on the left is shown a healthy brain, and on the right, an Alzheimer's brain. And you can see the brain smaller. It's a lot smaller. And there are these holes in the brain where there used to be cells. So that's where the term neurodegeneration comes from. There are cells that are normally present in the brain that are dying, and they're dying sometimes in regions that are important for memory, and so that leads to the characteristic memory loss associated with Alzheimer's. So theories of Alzheimer's and the pathology have to account for the fact that cells are actually dying. You're losing cells. It's not just that the cells aren't working as well, they're gone. So if we take a closer look at this Alzheimer's brain, what do we find? Well, actually, Alzheimer's did that on Dieter, the first patient, August Dieter. When she died, he did a post-mortem analysis, took thin sections of her brain and to look and see what was different. And he found some very interesting abnormalities. One thing he found, and Rick alluded to this, were these so-called 80 plaques. These are clumps of protein that reside outside the cells, and they're made up of a small peptide, which is called beta-amyloid. Rick mentioned, I'm going to call them 80 plaque proteins just for simplicity. I don't have time to go through all the details, but we do know that the proteins in this plaque, this gummy stuff, they can cause Alzheimer's. It's not just a bystander, that those proteins can drive the cause of Alzheimer's, so we have to take that into account. He found some deposits in the cells, but in the very first patient, in August Dieter, he also found vascular defects in the brain. So from the start, from patient number 1, there was an interaction or a connection between the cognitive decline in Alzheimer's and vascular effects in the brain. So we know that there's dementia caused by Alzheimer's disease. We know that there's dementia caused by vascular disease. For example, stroke. That's not Alzheimer's, that's purely vascular. So there are these two types of dementia, but in addition, there's tremendous overlap between these two types. And in fact, if you look, most Alzheimer's patients have vascular abnormalities. Not all, but most do. So then the question is, if there's a connection between Alzheimer's and vascular abnormalities, is this a correlation or causation? And so what do I mean by that? What I mean by that is the following. If you look at Alzheimer's patients, most of them probably have some sort of joint problem. And the reason for that's pretty obvious. Alzheimer's patients are mostly elderly. Most elderly people have some kind of joint problem, so there is a coincidence of these two pathologies. But no one would suggest that Alzheimer's is causing joint pain, joint problems, or vice versa. So that's just a comorbidity, it's called. But so do we have any evidence that the vascular defects actually contribute to the cognitive decline, or are they just there because people are getting old? Well, one thing we know from epidemiology is that there are risk factors for Alzheimer's disease that are vascular. For example, high blood pressure. People with high blood pressure have an increased risk of Alzheimer's. With diabetes. And there's decreased of Alzheimer's with anticoagulant treatment and with exercise. Lots of studies that exercise helps, which I'll come back to at the very end. So there is epidemiology, but that doesn't really prove that there's any real causal connection. So how can we do that? Well, one way we can do that is take advantage of a particular form of Alzheimer's, which I will call familial AD, familial Alzheimer's disease. This form of Alzheimer's is caused by mutations in the genome, and if you get one of these mutations, you get Alzheimer's disease. It's strictly genetically determined. And every patient that gets one of these mutations, and there's dozens of these mutations that cause Alzheimer's, gets the disease. So how does this work? I've just created a representative example here. This is like in one case, say with this mutation, the individual gets AD, meaning cognitive impairment, at age 50. It's a dominant disease for those geneticists in the auditorium. And so that means if this patient has children, there's a 50% chance that his child will get the mutation. And if his child gets the mutation, the child invariably gets Alzheimer's at about the same age. And a 50% chance the child will be okay. If the child has children, same thing. 50% chance that he passes on the mutation to one of his children, 50% chance, okay. This is a terrible burden for a family, obviously, terrible. But it does provide an opportunity to look at what happens as a function of time in Alzheimer's. Because you can study, for example, these two siblings. This one a carrier of the mutation, this one a non-carrier of the mutation. We could know, since we know the mutation, from day one of birth, that this child is going to get Alzheimer's at 50, from day one, and this child is not. So that gives us the opportunity to look as a function of time, let's say at 5 years old, at 10 years old, 15 years old, and ask, is anything going wrong before there's frank cognitive impairment? And people have done these experiments, and the results are quite interesting. The very first defects you see are in these 80 plaque proteins, up to 4 decades before there's any cognitive problems. The next defects are in blood flow, up to 33 years before any cognitive impairment. So just imagine what I'm saying. In this representative case, this kid is going to get Alzheimer's when he or she is 50 years old. But at age 17, he or she already has blood vessel defects in the brain. Now, no normal 17-year-old will have blood defects in the brain, so this is strong evidence that there are blood vessel changes that contribute to the disease, that help drive the pathology. And so then the question is, how can we study this possibility? It's pretty strong at this level that there's some connection, but we'd like to have some molecular connection, because if we're going to treat it, we need to know what are the molecules. So about 15 years ago in my lab, there was a student, Justin Paul, and he came to me all excited, and he said, I've done something really interesting. I've made a blood clot in a Petri dish. And here's the blood clot he made in the Petri dish. This is very highly magnified. These cables are blood clot proteins, and he was very proud of this. And I, wanting to be supportive of my young colleagues, I said, congratulations, Justin. You've done an experiment that was probably done for the first time 150 years ago. Now, Justin was not deterred. He said, yes, yes, I know that. I know I'm not the first to do this. But look at this. Look at what happens if I make a blood clot in the presence of the 80 plaque protein. So this is the same kind of clot form. The only thing is we've added the plaque protein into this clot. And you can immediately see it's very different. It's irregular, they're clumps. It just doesn't look the same as well ordered. So this was interesting and led to the following conclusion: with 80 plaque, the clot thickens. So let me digress just for one slide about blood clotting. You're all familiar with blood clotting. We have circulating in our blood vessels soluble blood clotting proteins. If you're injured, they're converted to insoluble forms, and those are the blood clots that we know and know very well. And those blood clots have two important functions. First, they stop the bleeding. They provide a barrier to blood leaking out of the brain. And second, they induce inflammation. They recruit white blood cells into the area to clean up the mess that was the injury. This is obviously critically important for us, our survival, but what's also critically important is the degradation of blood clots, because you don't want them hanging around. And once they've done their job, you want to get rid of them because you don't want this inflammation going on. So we decided to look at this degradation because we were wondering, does this funny clot structure lead to any functional differences in the clot? How can we study that? So Justin made a clot. This is a clot shown at lower magnification. This is a normal clot, and he made the clot fluorescent so you can see it. And here's a clot made in the presence of the 80 plaque protein, which you see the clumps and the irregular structure. And now what he's going to do, what he did was he put a clot-busting enzyme down here and looked at the dissolution of the clot as a function of time. And when he does that, you'll see that the clot on the left, the normal clot, is degraded rapidly and absolutely completely. And the clot on the right is degraded more slowly, and the clumps are not degraded at all. So this suggested that this funny blood clot that Justin had found had functionally different properties and was hard to degrade. Now this is in a test tube. We were interested in doing this in a live animal, and for that we turned to a mouse model. We have mice that have a form of Alzheimer's disease, and we can compare them to normal mouse. And so what we've done in this case is we've made a little window in a mouse skull so we can see the mouse brain and see mouse blood vessels. So this is a normal mouse we're looking at, and what we're looking at here is this is a little window into the brain of the mouse. And what you can't see right now, but you'll see in a minute, there's a blood vessel running horizontally through this mouse tissue. And we have formed a blood clot in that tissue. That's this black structure. So this is a picture of a mouse brain with a blood vessel in one of its cerebral blood vessels. And we're now going to do exactly the same experiment that was done in the test tube, but now in a whole mouse. We're going to add the clot-busting enzyme to this tissue and ask, can we degrade this clot? And the clot-busting enzyme is called TPA. Some of you may have heard of it. It's well known it's used in the clinic as a clot-busting enzyme for heart attacks and strokes. So the image shakes because the mouse is alive and breathing. So if you look at this, when you add TPA, you see almost immediately there's some flow through the blood vessel, and at about 2.5 minutes up here, the blood vessel opens up completely, and right about now, and now the blood is flowing. So we can take a normal mouse that's got a blood clot in the brain, and we can degrade that clot with TPA. What happens if we do exactly the same experiment in an Alzheimer's mouse? Here, the blood vessel, you can see better, is running more vertically, and we're going to do the same experiment. It's a window into the mouse, but it's an Alzheimer's mouse, so now there's a lot of AD plaque protein floating around in here, and we're going to add the clot-busting enzyme. And when you do this, you'll see that the clot is very refractory to degradation. It just sits there. And it takes many, many minutes for this clot to eventually be degraded. So, of course, this would be bad news if a clot was present in the brain and couldn't be degraded, because there would be lots of bad consequences about that, and I'll tell you about. Okay, so we've progressed from a test tube experiment to a mouse experiment. Well, is this true in humans? We would want to know. So obviously we can't do experiments like this in humans, but we can look at the Alzheimer's brain, which we've done here. So in this case, we've taken post-mortem brains from an Alzheimer's patient, made very thin sections, and then stained them to look at these AD plaque proteins. And you can see in this brain, there's a lot of AD plaque protein. Here's another one with an AD plaque. If we also stain the tissue for blood clots, it stains in almost exactly the same areas as shown on the bottom. And I should emphasize, if you took a normal age-matched person, there would be absolutely no plaque, and there would be absolutely no blood clots in the brain. So this then suggests that Alzheimer's patients do have more blood clots in the brain. So why is that? So we thought about that. As I've shown you that blood clots have decreased degradation in the presence of this AD plaque. But of course, we were wondering, is it possible that there's increased clot formation as well? So for that, we have to do one more slight digression into blood clotting. It's not a technical one. So this is the system I showed previously. There's a soluble blood clotting proteins forming blood clots. It turns out there's two blood clotting systems. There's a primary system, and that's the one that really drives clotting and is important for our survival. So if you don't have this primary system, you're a bleeder, you're hemophiliac. But there's also a backup system which forms clot, the exact function of which in the body is not well known, but it can form clots, and if you get rid of the backup system, people don't bleed, and there's really not much consequence. So we're interested in this backup system. So a student in the lab, Daria Zamolodchikov, came to me all excited one day and said, I have something very interesting. I can run this experiment. This is called a gel, and I can tell the difference between an inactive backup clotting system, shown here on the left with these single black lines, or an active blood clotting system, which you can see is very different. Always wanting to be supportive of my young people in the lab, I said, congratulations, Daria. You've done an experiment I think was first done in 1955. And she said, yes, I know that. But where do you think the blood came from that I used to work out this assay? And then she showed me that the blood on the left with the inactive blood clotting system came from normal patients, and the blood on the right came from AD patients. So this obviously piqued our interest tremendously because it suggested that in the AD patients, this backup blood clotting system might be activated and might drive more clotting. And so then the question was, is this important for AD. Now, we've studied this in the lab. Pradeep Singh, Zulin Chen, and Aaron Norris have studied this, and I'm going to talk about their work now. So the first experiment was, what would happen if we disabled the backup clotting system in normal and AD mice? So mice have the same kind of system, and we know that AD mice have cognitive impairment just like humans with AD have. So what would happen if we got rid of this clotting system? Would that make the AD mice do any better in cognition? So first you have to have a way to measure cognition in a mouse. And the way we do that is something called a Barnes maze. So this is a Barnes maze. It's a big platform which is very brightly lit, and it's got a series of holes around the outside, as you see. Most of these holes are dead ends, but one of them leads to an escape hatch that lets the mouse get away. The mouse hates it up on the platform, does not like to be exposed, and wants to get out of sight. There are also visual cues on the wall. So what the experiment consists of is you take a mouse, a naive mouse, you put it here. It wants to get away, it doesn't know how. It starts exploring. Eventually, it finds the escape hole and it goes down it. If you put the same mouse back on it, it remembers where the hole was because it looks around the room and sees the visual cues. It's kind of like when I come out of the subway at 59th and Lex. I always look for Bloomingdale's because I know if I go to Bloomingdale's, I'll be going home. So that's what the mouse does, and the mice get very, very good at it. So you can train the mice to do this, and it's a measure of spatial memory. So let me show you what happens if you take a normal mouse. The mouse has been trained multiple times. The mouse is hiding in here, and this is the escape hole. These are all dead ends. And you'll see that this little guy remembers very, very well where to go. Looks around for Bloomingdale's, takes off. So that's a normal mouse, and it's a very robust effect that you see. Now, if you take an Alzheimer's mouse, shown here, you'll see that it's very, very different. It's been trained the same number of times as the normal mouse, but the mouse, you can almost sense the confusion, does not remember the previous trials and does not remember where he's supposed to go. He almost gets there, and then he takes the wrong turn at the very end. So there's a little guy not knowing where to go. Almost, almost. So then the question was, what would happen if you took an Alzheimer's mouse and disabled this backup blood clotting system? Would that have any effect? And this shows the results of such an experiment. So you remember how confused the Alzheimer's mouse were. This mouse is not as good as the normal mouse, as you'll see. But it's not bad. It takes a while to figure out what's going on. And then, once it does pretty well. So the therapeutic implications of this are pretty obvious. That we think that there's this backup clotting system, that the AD plaque proteins are driving the clotting and forming these abnormal clots, which cannot be gotten rid of. And so if we could stop this backup clotting system, we might improve the outcome of Alzheimer's patients. There's two important things to note about this backup blood clotting system. One, as I've mentioned, it's not essential for clotting. You could say that if clotting is important for Alzheimer's, just give people anticoagulants. Give them Coumadin. Well, the reason you don't do that is because, as many of you probably know, there are serious bleeding complications from treatments with general anticoagulants. Alzheimer's patients have fragile brains, and anticoagulants, general anticoagulants, can lead to bleeding in the brain, which is very, very serious, in most cases fatal. So this system does not lead to bleeding, and so you can knock it out without the same kind of consequences. And furthermore, since this backup blood clotting system is important in some other pathologies, there are FDA-approved drugs already that inhibit the system on the shelf. So if we could establish that it's an important part of the pathology, there are things that we could do right away. Conclusions from our work. I mentioned that AD plaques increase the formation of abnormal clots. These clots can lead to blood vessel occlusion, and I didn't mention, but they can also lead to persistent inflammation, which I think actually might be a more important pathology for persistent clots. And inhibiting this blood clotting system improves AD in mice. Now, I'd like to just take a minute to draw an analogy to cancer research and what we've learned about cancer. So when I was a boy, cancer was considered to be one disease, and there was search for what was called the magic bullet. The implications, they weren't implications, they were directly stated, that there would be a drug that would cure all cancers. And we now know that that's incredibly naive, and that's not going to happen. Cancer has many different causes, it has a mixed pathology, and what we do now when a patient arrives in the clinic is stratify the tumor as to the specific characteristics and then treat that specific kind of tumor based on the pathology. So that's what I think we need to do with AD. We need to characterize the type of AD, and for that we need to develop stratification biomarkers that are simple to measure and quantitative. I'm going to go through this in a second. There's even a term for this now, and I just learned this recently, diagnostics, which means basically diagnostics used to develop therapy. So they're diagnostics not just to tell somebody if they have the disease, but what exactly are the characteristics of that disease so we can personalize treatment to that kind. So we've been working on kind of stratification biomarkers, and this backup clotting system provides one. We can take a tiny little bit of blood, and do a reaction with it. And if the backup clotting system is inactive, we don't get any color. If it's active, we get a dark blue color. And this is a very simple test. It can be done on a tiny amount of blood. It's quantitative, it's fast, it can be scaled to hundreds of. So I think that there's a possibility to use this as a stratification test for Alzheimer's patients. So here's the idea, basically, that a patient presents with cognitive decline. If they're given an AD diagnosis, we can further characterize that. Do they have vascular problems? Is it pure AD? And do they have inflammation? And depending on what answers we get on these, we can treat one, two, or all three of the pathologies. Combination chemotherapy has revolutionized cancer chemotherapy, and I think it's coming for Alzheimer's disease as well. So the recommendations are, like Winnie the Pooh here, keep in good cardiovascular shape. If we're right about the overlap between AD and vascular problems, I think it will slow the development of the disease. And if we're wrong, it will help in lots of other ways. So I have a few acknowledgments I'd like to talk about. One, none of this gets done by me. It's all done by my lab, and here's the current incarnation of my lab, a fantastic group. Is very, very international, as is Rockefeller. And this, I'd like to thank them for all their hard work, and also my past lab members for all their hard work. Now, on the sad note that Rick has also mentioned, my lab is the Patricia and John Rosenwald lab, and I have been deeply honored for that designation. We lost Pat, as Rick has said. She was a dear friend to me and will be deeply, deeply missed. I'd like to thank the people that have helped our work along. We've had lots of help from lots of people because the work is expensive, and we couldn't do it without the financial help. Just to orient you, there you are. And then finally, just a word or two about Rockefeller. Rick very eloquently talked about it at the beginning, and I'd just like to reiterate what he said. It's an incredible place. Just the amount of talent around here is just phenomenal, and talent in all disciplines. So that means that my lab has profited from interactions not just with neuroscientists, which you would expect, but with structural biologists, with chemists, with mathematicians, with physicists, et cetera. So it's a phenomenal place, and I feel very blessed to work here. Thank you very much.
That was magnificent.
Thank you.
So
thank you, Sid, for that terrific talk. We have time for some questions. We have microphones in each of the aisles, so if you have a question you'd like to ask, please raise your hand, and a microphone will get to you. In the meantime, the two observations. One, I'm sure something burning in all the audience is, what's the drug that is capable of inhibiting the backup clotting system, and where can I get some? And the second is the advertisement for that assay about how good your clotting system is. You've got that set up in the lobby?
Well, the drugs have been developed by other people, and they're used to stop the clotting system. It's a complicated system because, without getting too technical, there's two arms of it. There's a clotting arm and an inflammation arm. And the drugs that have been developed block the inflammation arm, so we think we might need some that block the clotting arm too. But the assay works very well, and we're trying to validate it in large numbers of patients right now.
Terrific. Questions? We have a question here. Others? If you have a question, raise your hand. There's a question there.
Yes, with regard to the drug, is it one that has to be given periodically, and is it financially affordable to people who suffer from the onslaught of Alzheimer's?
Yeah, the current drugs that I mentioned they would have to be given chronically, but they're very affordable. Well, they should be readily affordable. They're not readily affordable now because the company that developed them is charging too much for them, but eventually they will be very affordable.
So a question back there, and then a question here on the aisle in the third row.
Okay, my question is, when do you think that there will be drugs available to, at the very least, reverse the neural degeneration that accompanies Alzheimer's disease? Do you think there will ever be any drugs that cure Alzheimer's in effect?
Reversing it is a tough thing to do, of course, although I used to think it was totally impossible. I'm not so sure it's totally impossible now. But I think what's going to happen here is we're going to chip away at it, so to speak. Like if maybe people get Alzheimer's, and if you could block the vascular complications, maybe the disease progresses more slowly. It doesn't have to be that much more slowly to make a big impact. If you could slow it down by a factor of 2, then most people would age out, so to speak, before they got serious cognitive problems. So I think we're going to chip away at it, and then hopefully eventually get to a point where it's not a factor. But in terms of a total cure, reversing the ravages, that's going to be tough.
Question right here on the aisle.
So are there any data on the incidence of Alzheimer's with hemophiliacs?
It's a very interesting question, and I, for years, wondered why we didn't have better data about that. And it turns out that we don't, in large part because the people that are of Alzheimer's age now, the hemophiliacs were devastated by the AIDS crisis because they got blood transfusions years ago, and those blood transfusions carried HIV, and they got AIDS, and they died. So we haven't had enough patients really to look at, but that's going to change, and we're going to be able to look at that. There is evidence that anticoagulants do reduce the risk of Alzheimer's. That's been done in a study with a disease called atrial fibrillation, and some patients are put on anticoagulants, some are not, and so people have examined the plus and minus there, and the people on anticoagulants do fare better.
Stuff like Eliquis?
Sorry?
Stuff like Eliquis?
Yeah, yeah.
I wondered, with this new term that's being tossed around, precision medicine, are you following that in any manner? And also, there's a lot of discussion about stem cell work and research, because we've exhausted the drugs for the moment, and they are not, we're looking at other things, and this is a fabulous presentation. Thank you very much.
Well, I'm not sure it would be called precision. It's not that precise, but it's personalized, certainly. I think people might complain if I called it precision. And stem cells, they're definitely being looked at. There are studies out there, people injecting stem cells in mice into the blood vessels to see if they can colonize the brain and whether they could bring back any function. So I think that's definitely going to be a very big area of interest.
Here and then here.
Thank you. Are you aware of any research like yours being done across America or worldwide? Are you working with any other labs?
Oh yeah, there are a lot of people interested in this aspect. We're not alone at all. And yeah, we've collaborated with people even across the street in Weill Cornell who are working on vascular issues. So there are a lot of people. It's the pendulum swings. When we started, there wasn't a lot of enthusiasm, I would say. But now I would say we get very little resistance when we say that the vascular system is an important component.
Question right here.
Do we know what causes the formation of plaque?
It's a very small peptide, if you know what a peptide is. Peptide's a small protein, and it just aggregates. It spontaneously aggregates. So if we make this peptide in the lab and put it in a test tube and just let it sit on the lab bench for a day, it forms aggregates. So for whatever reason, this peptide aggregates spontaneously, and that's what forms the plaques. And we know a lot about how the peptide is made. I didn't go into all that, but we know a lot about where it comes from and how it's made.
Sid, I can't resist asking you about ApoE4,
Yeah.
one of the major risk factors in the general population, which was first known before its risk for Alzheimer's disease for its impact on cardiovascular disease.
Exactly.
Does this impact the clotting process that you look at all?
We haven't been able to exactly nail that down. What Rick's referring to is there's a cholesterol-carrying drug called ApoE. It exists in 3 forms. ApoE2, E3, and E4. And if you have E4, you're at very high risk for Alzheimer's. And we've tried hard. It's difficult because the mouse models haven't really quite gotten to the point that we need them to. But I think it could well.
Question back in the back.
In the case where you have genetically derived Alzheimer's, is there anything distinctive that you do in the genetic testing of a young person to determine whether they are likely to have this?
They're not screened for this in general. The families that have this disease are pretty well known because, like I said, that Alzheimer's is very early onset, sometimes in the 30s. So those patients, we know what mutations they have. We can sequence their genome and determine which mutations they have. But it's not regularly screened for in the population.
Question here.
Does that answer your question?
Yes, I think so. It's just standard genetic sequencing.
Yeah, exactly. That's how it can be determined, yeah.
A bit related to the last question, is your team looking into how they could use gene editing technology to prevent the disease before it is trans?
Yeah, sure. Well, that would be tough as an adult, obviously. But yeah, that's possible in embryos or things like that. But since we know the mutations, but there may be other ways to do that you don't have to edit, but rather maybe select for embryos that don't carry mutations, that sort of thing.
Thank you.
Sure.
So a couple of questions down here in the 3rd row.
Dementia, or is this just a step towards Alzheimer's?
It's a form of dementia. It raises kind of an interesting point, which is, what's the definition of Alzheimer's? And you would think that would be an easy thing but I can tell you, we have spirited arguments amongst the people that work about what really determines it, because there's other kinds of dementia. And I think really what often determines it is the presence of these plaques, these AD plaques. that really tells you that something's going on that's Alzheimer-like.
There's another question here in the third row.
Is it possible that your work would have a diagnostic element to it?
Absolutely, absolutely, but I should caution about the backup clotting system. It's not unique to Alzheimer's. So that's where I think that's what you're driving at. And so you can't just take people and look for the activation of this backup clotting system, and if they've got it, say, you got Alzheimer's. That wouldn't work, because there are other pathologies that lead to this system being activated. And so the analogy would be kind of like in cancer. One of the characteristics that people look for in breast cancer is hormone receptors. Now, hormone receptors are not just present in cancer cells. They're present in normal breast tissue as well, and ovarian tissue. So you couldn't use hormone receptors as a standalone marker for cancer, but once you know that you have a tumor, you can use it to characterize that tumor and use a better therapy. So I think that would be the same thing here. Once you have cognitive decline and you do have activation of the clotting system, you could try to knock out the clotting system because it's probably related to the Alzheimer's.
A question back here.
Any hope to cleaning out beta-amyloid accumulations once it's started and being recognized to be a problem?
I can't see where you are.
Here.
Oh, I see. Yes, well, yes, there is hope for clearing out the plaque. People have used passive immunology. In other words, they inject antibodies against the A-beta plaque. And those antibody injections often clear out the plaque pretty dramatically in some cases. The problem is that they don't really help with cognition, or haven't yet. And there's some possible reasons for that. But I think we do have strategies to be able to clear out the plaque, no question.
Question here.
Hi, over here. Does aspirin have any impact on this backup clotting system?
It does not, and it doesn't really help in Alzheimer's, but NSAIDs do. It's complicated because there's lots of studies and there's every kind of result, but it looks that if you take a non-steroidal anti-inflammatory drug, it does have a minor effect on the incidence. So the inflammatory part is an important part of what you're kind of driving at.